All right, so now let's talk about the pathophysiology of meningitis, and I will chip in the clinical manifestation as well, and then also chip in the diagnostic investigation during the explanation of the pathophysiology. So, as I said, the meningitis always begins with a primary infection. So, primary infection. So primary infections like otitis media, pneumonia, sinusitis, septicemia. So when someone have any of these infections and more, and this infection is not well resolved, and the infection gets into the blood, the infections get or seep into the blood. This contaminated blood is being carried to all parts of the body, including the brain. And so there is a hematogenous spread. To the meninges. And when they get to the meninges, the inflammation begins. Now, the meninges, we said we have three layers. We have the dura, the arachnoid, and then the pia mater. But inflammation of the meninges can occur in any of these layers, but mostly they prefer the subarachnoid space. So most of the meningitis or the inflammation of the meninges occurs within the subarachnoid space. And I want to bring the subarachnoid space here. Now, why does the bacteria always prefer the subarachnoid space? One, we said there is glucose within the CSF fluid is found within the subarachnoid space, and that CSF has what? Glucose, it has what? Protein, and there's also oxygen within the CSF, which the organism can use to energize them to fight or to cause more infection. So I bring my subarachnoid space here. So when the bacteria get into the subarachnoid space, then they elicit inflammatory process. Now we all know that within the brain there are barriers that prevent organisms from entering into the brain, but the barrier that is found within the subarachnoid space is so fragile that any bacteria can break it and then enter into the subarachnoid space to cause infection. And so let's say we have our bacteria here, which is an antigen here, breaking the barrier to cause infection. So they break it and then they now enter. Now earlier on I said that the subarachnoid space consists of CSF. So we have this as our CSF. Now we have a bacteria that have entered, and the bacteria is going to cause inflammation. And inflammation, we know that one of the key things that happen is increased permeability and vessel dilation. That means that more of the blood that contains the bacteria causing the infection can get into the subarachnoid space. So increased permeability, they are breaking the barrier, allowing more blood to get into the subarachnoid space. So that means that the volume of fluid, which originally was CSF, has now been increased, and that would lead to. So one of the clinical features that occur in bacterial meningitis is increased ICP, increased intracranial pressure, because of the blood that is being gushed into the subarachnoid space increases the pressure within it, and that will lead to increased intracranial pressure. And with increased intracranial pressure, it is always associated with headache, coma, drowsiness. Now, Another thing that can also happen when there's a gush of blood into the subarachnoid space is that the fontanel here will bulge. And so we have another clinical manifestation, which is what bulging fontanel. But this bulging fontanel is usually not found in adults, but rather infants. So children of 1 year old and below. So we have bulging fontanel. And as well, infants also or neonates also experience increased intracranial pressure. Now, let's continue. So during the inflammatory process, the meninges are being inflamed and they are being what? Irritated. And so what will happen when there's irritation of the meninges? One of the clinical manifestations is Brudzinski sign. So we have positive Brudzinski sign. How does this thing occur? Because of the inflammation of the meninges, it causes a hyper excitability of the spinal cord, and that causes the legs to raise when there's a flexion of the neck. And so with positive Brudzinski sign, when we lift the individual's head up, we see that involuntarily the legs also raise. It's because of the excitability of the spinal cord. Then another clinical manifestation that can also occur because of the inflammation of the meninges is the Koenig sign. Positive Koenig sign. Positive Koenig sign. Now, the positive Koenig sign also occurs because of the inflammation of the meninges, which causes excitability of the lumbar root, which is our back, the spinal, the lumbar root. And so this one will also affect the leg. And what happens is that when the individual leg is placed in a 90 degrees Celsius and the healthcare provider tries to extend it, the healthcare provider finds it difficult to extend it, and again the patient also feels pain, and that is known as what? A positive Koenig sign. And so the key thing that you just have to understand is that in Koenig sign, you position the patient leg in a 90 degrees, trying to extend it, the patient resists and the patient also complains of pain. That is what positive Koenig sign. Now, another clinical manifestation that also occurs is what? Fever. And that is because of the inflammatory process that is what? Ongoing. Then we also have another clinical manifestation, which is also photophobia. So photophobia also occurs because of the meningeal irritation that affects the nerve that is controlling the eyes. Then another clinical manifestation is also nuchal rigidity. Nuchal rigidity. And so the inflammation of the meninges can also affect the muscles of the neck, and that will cause stiffness of the neck. All these clinical manifestation also happens in neonatal meningitis or infant meningitis, with the exception that with the neonate, when there's an increased ICP, they cannot complain of what? Headache. And so maybe a question can be like that a neonate is diagnosed of meningitis. The nurse assessing the patient is expected to see all the following, except so when you see headache there, you cannot choose headache, because in neonates they cannot complain of what? Headache. Okay. All right. And then, as I said, the bulging fontanel is mostly seen among infants. And again, with the infants also, apart from the photophobia, the nuchal rigidity, and the bulging fontanel, they also experience high pitch cry. High pitch cry. So let me put it here for you. Infants, we have high pitch cry, we have bulging fontanel, we have increased ICP, and then we also have the stiffness of neck. In infants, you are likely not to see Brudzinski sign or the Kenning sign, and so the main clinical manifestation that we use to diagnose them is the high pitched cry, the bulging frontal, and then the stiffness of the neck, and then sometimes also the photophobia. But for adults or for older children, what the key clinical features are the positive Brudzinski sign, the positive Kenning sign, the fever, and the nuchal rigidity, and then also the ICP. Now let's look at the diagnostic investigations. So with the diagnostic investigations, we have lumbar puncture, for CSF analysis. Now, in taking the CSF, we need to also understand the position that we help the patient to assume before taking the CSF. And when we are done with taking the sample, what is the best position for the patient? And so I bring a chair here. Sometimes you can just let the patient sit down like this, and then the patient will pull the head forward in this way, and that will allow the healthcare provider to be able to assess the lumbar and then take the fluid from the fourth and the fifth lumbar vertebra, And when the sample is taken, what is the best position to help this patient to lie? That one too also has to do with what? Supine position. Because if the patient is lying on prone, if the patient is lying on side to side or any of the positions, it can also allow the CSF to leak down, and that can also alter the ICP or increase the ICP, which will also cause headache. And so after taking the CSF, the best position is to let the patient lie at the back, which is a supine position, to prevent leakage of blood or the CSF and preventing change in the ICP. Now, in taking the CSF to the lab, when the results is out, one of the things that we need to look at is the color of the CSF. Now, we said that the CSF is colorless, but after the inflammatory process within the subarachnoid space, if it is bacterial meningitis, the color will change to become what? Colorless. But viral meningitis does not cause colorless of the CSF. And so one of the things that you used to know that if about this particular meningitis, if it is bacterial meningitis or a septic meningitis, you can use the color of the CSF. If it changes from colorless to what? Cloudiness, then it becomes what? A bacterial meningitis. Then we can also look at the glucose level, we can also look at the protein level in the CSF. And so we know that we said that during the inflammatory process, there is increased permeability and vasodilation, which is bringing more blood here. And the blood also contains what? Protein. And so we expect that the protein level in the CSF after the inflammation will what? Increase, because more blood is getting to this side. Now, what of the glucose? The glucose level is expected to reduce because the bacteria and the antibody that also comes to fight against it are also going to depend on the glucose within the subarachnoid space, and so we expect that the glucose level will reduce, and that will also tell us that yes, this is bacterial meningitis. Now let's see how we can manage this condition as nurses. So as nurses, observation and assessment. What are we going to observe? Now, we have to understand that in meningitis, there is an inflammatory process that can lead to hemolysis. And so red blood cells are being broken down. When red blood cells are being broken down, it can reduce the pressure, okay? And that can lead to what? Shock. And so we need to monitor for signs of shock. Okay, because of the hemolysis, there can be what? Shock. So we need to monitor for signs of shock. And what are we going to do here? We need to check the capillary refill time by pressing on the nail bed to see the time that it will what the blood will be refilled. And we all know that anything that is greater than 3 seconds means that there's a poor capillary refill time. And then we also need to check the heart rate. And so if the heart rate is slow and bounding, it is also a sign of what? Shock. Then we also need to check the blood pressure to see if it is low or high. If it is low, then we know that the patient is at risk of shock. Now, what else again are we also supposed to examine, or we need to observe for this particular patient? So all other vital signs, including the temperature, the RBS. Okay, so we need to also assess for the temperature and the RBS. Now, what another thing we can also do as nurses in managing this patient is nutrition. So here in nutrition, we are looking at the kind of food to give to these patients and how do we feed the patient. Is it by mouth or is it by NG tube? So that depends on the assessment findings of the patient. Now, remember we said that one of the clinical features is stiffness of the neck. So if this patient is having stiffness of the neck, we cannot ask the patient to put the food into the mouth, but rather the feeding will be either parenteral feeding or NG tube if there is what? Nuchal rigidity or stiffness of the neck. Now, so if the rigidity or if the muscles are relaxed and the patient is not having nuchal rigidity or stiffness of the neck, then we can feed the patient by mouth. Now, what type of food do we give? We need to give adequate diet, which formally we say balanced diet. So a food that is rich in calories, the carbohydrates, the proteins and the vitamins that will help the patient to recover. Now, in one of the clinical features, we also talk about increased ICP. And so patient is having an increased ICP. What is the best position to nurse this patient in order to reduce the pressure within the subarachnoid space, in order to prevent the head, in order to reduce the headache, the coma, and the drowsiness that comes with increased ICP? And so we elevate, so the position is elevating the head side to at least 35 to 45 degrees Celsius. So we are elevating the head side of the bed to 35 to 40 degrees Celsius, and that will help to reduce the pressure within the subarachnoid space. Then another thing that we can also do for this patient as nurses is to remember the photophobia and the irritability. So we said patient will have photophobia and irritability. So what do we do for this patient in terms of the light? Is by nursing the patient in a dark room. That is an adult patient. But if it is a neonate, we cannot nurse a neonate in a dark room. That child will be crying. And so the best one will be what? A dim light room. A dim light room for neonates or a young child. And that will help in solving the issues of what? Photophobia. Then we talk about the irritability. What do we do in relation to the irritability? So this irritability is known as paradoxical irritability. Paradoxical irritability. They become irritable when they are being touched, and so to ensure that they have adequate rest and not causing seizures, which is also one of the clinical features of meningitis, what we need to do is bulk nursing. Bulk nursing. And so we do everything at once for this patient. If you want to check your vital signs, you don't first check the temperature, go and document and come, and then later you come and check the BP, go and document and come. No. If there's a need to check vital signs for the patient or also administer medication, you can gather all these activities and do it at once so that you don't cause unnecessary irritability to these patients. Then another thing that we can also do for this patient is restrict visitors. Is to restrict visitors. Okay. Then again, we can also reduce the noise in the ward, because that also irritates them. Then we talk about medical management. So with the medical management, we have IV fluids, we have antibiotics, and then we have anticonvulsants, and then we also have analgesics. Now, remember we said that during the inflammatory process, there is hemolysis, and that also reduces the blood volume, which can lead to shock. And so one of the things we can do is to give IV fluids, specifically isotonic fluid, that will help to expand the blood volume to prevent shock. And then we can also give antibiotics, and antibiotics we can give the third generation type of antibiotics to deal with the infections or the bacteria that are causing the inflammation. So ceftriaxone, ceftriaxone, cefizim, all these antibiotics can be given. And then we also said that in meningitis there is a nuchal rigidity, that is the stiffness of the muscles, the neck muscles and then the leg muscle. So we need to give them a drug that will help to relax the muscles. And one of the drugs is what? Diazepam phenobarbital. Now, in adults or in older children, diazepam can be given, but for neonates, it is always preferred that we give them phenobarbital because of the respiratory effects that diazepam can have on the neonates. And then we can also give analgesic. Remember, we said one of the clinical manifestation is headache, and so if there's any pain, then we give also analgesic. Now, we can also give sodium bicarbonate. Sodium bicarbonate because of the acidosis that can occur. So it means that the only time you can give sodium bicarbonate is when you are assured that there is what acidosis or the pH of the patient blood is what low. Then we can also give calcium gluconate. Calcium gluconate, and that also depends on the calcium level of the patient. Now, in meningitis, since there's an inflammation of the cells, which also reduce the amount of blood supply to the tissues. That can also lead to tissue death, and which will also increase the phosphorus in the blood. And we all know that when phosphorus levels are high, calcium level what goes low, and so that can lead to what hypocalcemia. And we know hypocalcemia is also one of the things that can also lead to seizures in meningitis, apart from the irritation of the meninges. And so when that happens and your laboratory investigation shows that there is hypocalcemia, then you can give what calcium gluconate. And so this too depends on the assessment findings. Thank you very much for staying with me. I believe you enjoy these lectures. If you do, press on the subscription button, the like button, so that you'll see me in the next video. Thank you.